So I am very excited to chat with Dr. Deva Boone, who is one of the most experienced parathyroid surgeons in the United States. So obviously we're going to be chatting about the parathyroid glands, also talk about vitamin D. But Dr. Deva was the medical director and senior surgeon at the Norman Parathyroid Center until 2020 when she left to open the Southwest Parathyroid Center, which is located in Phoenix, Arizona. And thank you so much for joining us, Dr. Deva.
Hi, yes, thank you for having me.
Yeah, really excited to talk with you about the parathyroid glands. And can you just give a brief background? Like, how did you decide that you were going to focus on the parathyroid glands? Was it something like you knew when you were in medical school or upon graduating? Did you have like a personal
Yeah,
experience or, yeah, how did you decide to
sure.
focus on that?
Yeah, no, it wasn't really that. I went to medical school, not even knowing I was going to be a surgeon. I thought I was going to be a neurologist, and then during my rotations in third year of medical school, I really enjoyed surgery, and so decided to do general surgery. Didn't really decide on parathyroids until the end of that residency. I really liked endocrine surgeons. I did a fellowship in endocrine surgery, and then I went down to Tampa um, to work with the Norman Parathyroid Center because they do just parathyroid surgery, and I was just really impressed with the setup they had and the way they did the operation, and so decided to just focus on that forever. It is a really nice operation because you can really help a lot of people. A lot of people feel pretty bad beforehand, and they feel much better afterwards on average. And so it's pretty satisfying to be able to help people with this operation.
So, for those who are not familiar with the parathyroid glands, can you explain the function of them?
Sure. Yeah. So the parathyroid glands are um, kind of the forgotten cousin of the endocrine glands because a lot of people don't know about them. They are right next to the thyroid. So your thyroid, as I'm sure your listeners already know, but your thyroid is this butterfly shaped gland at the base of the neck. The parathyroid glands, they sound like thyroid because they have thyroid in the name, but that just comes from the fact that they're right next to the thyroid. So when they were discovered, we didn't know what they were, so they were called para next to the thyroid. So parathyroid glands, there's four of them. They are typically right around the thyroid, right next to it, two on each side. And they exist solely to regulate your calcium. So if you think about it, there aren't any other minerals in your body that have a whole organ dedicated to them. So they just regulate calcium. It's also the only thing that you have four organs of. So they're pretty cool. They are tiny. They are about the size of a grain of rice. Each one of them is about the size of a grain of rice. So there's these tiny little glands, but they're really important because they do regulate your calcium.
And why is that important? So, why is it important? Why do you need a
Right. So
separate
so why does
gland
that
to
matter?
regulate
Yeah.
calcium?
Yeah. So when most people think about calcium, they think about bones, right? All the billboards, got milk. Calcium is really important for your bones. That actually is the main storage location of calcium in your body, and calcium is what makes your bones hard. But the reason why the parathyroid glands exist is really not to regulate your bone calcium. It's to regulate the blood calcium because that actually is really important in itself. Your brain, your muscles, all your nerves, they all depend on having a set level of calcium in order to function properly. So, for your muscles to contract properly, for your brain to have correct signaling and good signaling, you actually use calcium during all of that process. So, calcium is necessary for that reason. It's necessary even in other areas where the electrical signaling is important, like in your heart. So, when your heart beats, it's because there's an electrical signal going through it. Calcium is necessary for that. It's necessary for blood clotting. And so for all of these reasons, your calcium in your blood is kept in a very tight range. Sometimes other things can sort of vary, but your calcium typically does not vary that much because your parathyroid glands are keeping in a really tight range so that your brain, nervous system, can all function properly.
So you don't want calcium to be too low. You don't want calcium to be too high. And that goes really with any nutrient. But
Right.
I think, yeah, when people focus on really any mineral or any nutrient, they're probably more concerned about deficiencies. Like, okay, I'm really concerned about having low calcium, and that might,
Right.
be a factor with osteoporosis. But what you see a lot in your practice is the opposite,
The
elevated
opposite.
calcium
Yes.
levels. And
Right. So it's interesting because, yes, low calcium is a problem. But what I see a lot more of is high calcium because I treat primary hyperparathyroidism. When the parathyroids have a problem, typically it's not a deficiency of PTH, it's that they have too much parathyroid hormone. So the parathyroid glands, they're pretty simple. They make one hormone called PTH, or parathyroid hormone, and that PTH is just regulating calcium and phosphorus, but that's a separate issue. But really, you can think of it as doing kind of one thing with one hormone. Um, and when you have a really low calcium level, and this is kind of just important to understand this thermostat concept, when you have a really low calcium level, your parathyroid glands, their whole job in life is to get that calcium up. So they sense that. Just like if you set your thermostat to 68 degrees and it starts to go below that, your thermostat will sense that, turns on the heat comes on, it brings the temperature back up to 68, and then the heating can turn back off. When that happens in your body, when the calcium level drops too low, parathyroid glands turn on, they make more hormone. The hormone then raises the calcium by doing a few things, like taking calcium out of your bones to put it in the blood. And then as the calcium rises and goes back up to the normal range, the parathyroid glands can kind of turn off, make less hormone. If the calcium level goes too high for any reason, the parathyroid glands turn off. Just like if your temperature went to 90 degrees, your heating should turn off. So the parathyroid glands are sort of regulating things throughout the day. And I do sometimes see people with low calcium because for whatever reason they have a problem getting calcium. If they have issues with chronic diarrhea or any problem with absorption from a gastric bypass, that kind of thing, they can have problems keeping their calcium up. But when you have a problem with the parathyroid glands, typically you see a high calcium level. And that is because when you have a parathyroid problem, most of the time it's due to a small, benign tumor in the gland. And that tumor is acting inappropriately, meaning it's just making hormone, even though it shouldn't, just keeps making it. And that means that parathyroid hormone continues to dump out, continues to raise the calcium level. So you end up with these high calcium levels. Now, most people, when they see that, they actually think it's a good thing because they look at their labs and, they are looking for deficiencies. So if they see that their potassium's a little bit low, they clue into that. If they see their vitamin D is a little bit low, they clue into that. If they see their calcium's a little bit low, they might worry about that. When they see it's a little bit high, they think, oh, well, that's probably good. That's probably good for my bones, right? To have a little more calcium because I've been taught that, I should take calcium from my bones. My calcium's on the high end. That's a great thing. And they don't realize that actually that's as much of a problem as having a low calcium, possibly more. So you really want to pay attention to keeping that calcium in range, not letting it go too low or too high, because remember, your brain, your nerves, your muscles, they all want that calcium to be in a certain range, and anywhere outside that range will cause problems.
all right, so thanks for explaining that. And so it's like it's a negative, so it's a negative feedback mechanism. I mean, similar to thyroid, like if you have low thyroid
Mhm.
hormone, you have TSH, which is thyroid stimulating hormone, that's signaling to the thyroid to produce more thyroid hormone. And so under normal circumstances, if serum calcium was low, you would want to see the parathyroid hormone elevated or high, again, signaling for the parathyroids to create more, to create more of the, I'm sorry, to increase the calcium levels, correct?
Right, right. And the parathyroid glands do that, like I said, through a couple of ways. But one of the ways that they get the calcium up is PTH actually stimulates the bones to release calcium. So that actually is how patients with these parathyroid tumors get osteoporosis. So you see that your calcium is high, but actually your bones don't have enough calcium because you see your bone density dropping, and that's connected. The reason your calcium in your blood is high is because it's coming out of your bones. You actually want it to go back in, but that is part of primary hyperparathyroidism, or having too much PTH or a parathyroid tumor.
And how common is primary hyperparathyroidism?
Unfortunately, it's more common than most people realize. So, as I said, a lot of people don't even know what the parathyroid glands are. They don't know what they do, and the issue with a lot of patients. So, just to get to exactly how many, it's hard to say, but it does increase as you get older, and it is more common in women. So, probably even up to 1% of women over the age of 50 will get this. So, it's most common in postmenopausal women. Having said that, I have had teenage boys with this. So it doesn't mean that you can't get it if you're younger. There are lots of people who get it when they're younger and get it as men, but about 75% of the patients are women, and the average age is probably about 60. And that, I think, gets into why the disease is underdiagnosed, because if you think about it, it tends to happen in women who are around the age of menopause. So a lot of the symptoms tend to get blamed on that. So if you've gone through menopause in the last 10 years and you start to tell your doctor that you're tired and you can't sleep at night, the immediate thing is not to check your calcium. The immediate thing is to respond with, this is probably menopause. And so I think that is partly why the disease gets overlooked a little bit. Another reason is that our labs give a very broad range for calcium. So that if you get your labs, and I encourage everybody to get their own labs, get the results, keep them for yourself in a file so that you have them and you can review them. But if you look at your labs, a lot of times what you're doing and what your doctor is doing is just scanning down for anything that's abnormal. So, they put a little abnormal note or they make it red. Oftentimes you get so many labs, you're just looking for that. But unfortunately, with calcium, a lot of the labs give a range that is, both too far on the low end and on the high end. So it'll say 8.5 to 10.5 is normal range, when really it's more like 9.2 to 9.9 is the normal range. 10.0 can be normal. But once you get up further in age, your calcium level, above about age 40, your calcium level shouldn't be in the tens. But the labs don't really adjust for that. And so you end up sometimes with people who have had high calcium for years, but it didn't register until the calcium went to 11. And so that's part of the reason why. But I think a big part is that a lot of patients are having these symptoms that are nonspecific, and they go to their doctor and it gets blamed on either getting older or menopause.
Can you talk a little bit more about the ranges? So you mentioned that as we get older, you shouldn't have a calcium level that's higher. So the serum calcium should decrease as you get
Right.
older?
So, yeah. So children actually can have pretty high calcium levels. Their calcium levels, and this is in U.S. ranges, right? So milligrams per deciliter. But their calcium levels are often in the tens, even up to 11. And then it kind of drops as you get older, so that in your 20s, a lot of people will have calcium levels in the tens, but a lot are in the nines by that point. In the 30s, maybe you can have some calcium levels in the low tens, but it kind of drops with time. And by the time you get to age 40, most of your calcium levels should be in that nines range. And as I said, it's kind of mid to high nines, like 9.2, 9.3 to 10.0. And if you're outside that range, usually it indicates a problem.
Okay. So if it's above 10, especially
Yeah,
above
or
40, then
10.0. So, and even a little bit, and it does kind of get the tighter as you get older. So if I see a 40-year-old with a 10.1, I want to check things out. That's not definitive yet. But if I see an 80-year-old with a 10.1 and they've got a PTH that's either normal or high, that's primary hyperparathyroidism. So, it kind of, the age thing is, it's a little, there's no clear cutoff. It's not like you wake up and you're 40 and suddenly your calcium level is a different level. It sort of slowly happens over time. And everybody's a little bit different. But in general, if you're 60 years old, really all your calcium levels should be 10.0 or under. You don't want it too low, obviously, but you don't want it to go above 10.0.
So if you see it above 10.0, as you mentioned, you look like you order a PTH, a parathyroid hormone test, to see if that is elevated. And if that's elevated, then that's typically indicating hyperparathyroidism.
That's that's the most common scenario, right? Is a high calcium and a high PTH. Interestingly, you don't need the high PTH, and that's why I kind of went over the thermostat analogy. So think for a second: if your house is 90 degrees and your heating is on, it's on low, but it's still on, then that's a problem, right? Your thermostat clearly is not sensing that it's 90 degrees because you should have turned the heat off. Um, or it should have kicked in and the heating should have come off. So it's like that with parathyroid glands. If you've got a calcium of 11 and your parathyroid hormone level is in the normal range, that's an inappropriate response, right? Because your parathyroid glands should turn off. All of your normal parathyroid glands are turning off. And so you'll have a very low PTH level if something else is causing the high calcium. If you've got a PTH that's normal range with a high calcium, that's usually primary hyperparathyroidism.
So we were chatting a little bit before going live, and with hyperthyroidism, a lot of people who are listen to this have hyperthyroidism, whether it's
Mhm.
Graves or toxic multinodular goiter, and some people with hyperthyroidism will have an elevated serum calcium as well. And so the way to know if it's related to the thyroid or if it's hyperparathyroidism is what you just said. If you would do let's say if someone has
Right.
hyperthyroidism, their serum calcium is 10.2. So you look at the parathyroid hormone and see, is it elevated or is it normal, because it should be on the lower
Or
side.
lower side. Yeah. Yeah, exactly. And you look at the overall picture. I mean, because there aren't that many things that can cause high calcium, first of all. So most of the time, just if you're gonna place a bet on somebody with high calcium, you're gonna bet that they have primary hyperparathyroidism because that just by far is the most common thing. But there are these scenarios with hyperthyroidism where you do get high calcium levels. The key, so with all of that, these issues, I want to see the history. So I want to go back and see, some of these patients, their calcium was high before they developed hyperthyroidism. So doesn't seem like that was probably it. Some people will, they will have, when their thyroid disease is particularly active, their calcium may rise. And this can be true with something like sarcoidosis too. So if they have very active sarcoidosis, you'll see the calcium rise. And then once it's treated, the calcium goes back to normal. And so that should sort of be true with the thyroid as well. If you're under control, if you haven't really had many issues, your labs are typically going to go back to normal. But tracking those over time with the calcium and the PTH and the vitamin D level all together is the best way to kind of figure it out.
All right. So you mentioned vitamin D. So vitamin D also, in some cases, can cause elevated serum calcium, correct?
Yes. So vitamin D is one of my favorite topics because it is intimately related to calcium and parathyroid hormone. And a lot of people really like vitamin D. A lot of people take vitamin D. I take vitamin D, but there are things you need to know about vitamin D. First, it's not really a vitamin because your body does produce it. And second, it's a hormone. So you have to treat it like any other hormone. And I think we know when we're talking about sex hormones or steroids, which are hormones, we kind of know you've got to treat those carefully because they're going to have these, they can have these systemic effects. But vitamin D doesn't always have that reputation because it's a supplement people can buy over the counter, and so I think it's sometimes not treated with the same respect. But vitamin D, it is essential. It is really essential for calcium metabolism. And one of the main things that vitamin D does, or active vitamin D, is help your intestines absorb calcium. So if you have a severe deficiency in vitamin D, you won't be able to absorb calcium appropriately. And this can lead to things like rickets. I mean, this is how low vitamin D causes a lot of these issues, is that you're not absorbing the calcium or properly handling the calcium. So vitamin D is essential for that. the way that it's involved with the parathyroids is that the parathyroids, part of the way that they get your calcium level up. So remember I said they sense that low calcium, they turn on, they make more hormone. Part of what that hormone does is activate or stimulate the activation of vitamin D that happens in your kidneys. So your kidneys, your vitamin D exists in multiple forms in your body. This is really confusing too, but we'll kind of keep it simple and just talk about the inactive form and the active form of vitamin D. To activate that form, you need parathyroid hormone. You need an enzyme. That enzyme is just directly stimulated by PTH. So PTH ramps up the conversion of inactive vitamin D to the active vitamin D, which then goes to the intestines and helps your intestines absorb calcium. So that's part of the ways that it will raise your calcium level. The way that this gets confusing, and this gets really confusing for doctors as well. So I have to explain this to doctors all the time also. So when you have a parathyroid tumor, you will end up with a low vitamin D level and a high calcium level. You should not treat that. That vitamin D is not, it's not real exactly. What they're measuring is the inactive form. That is the form that we measure on people. If I just say, I want you to get a vitamin D checked, and you go to the lab and I check off vitamin D, they're going to draw the inactive form, vitamin D 25 hydroxy. That's the form that is really accurate for most people, and it indicates your overall vitamin D status better than the other forms. The other forms tend to break down more easily, and they're not as easy to measure. Now, we can measure the active form, and we do sometimes, but in most cases we don't because it tends to break down quickly. It's not a good assessment of your kind of overall vitamin D status. Um, Inactive vitamin D is accurate for almost everyone, but it is not accurate for people with primary hyperparathyroidism. Because, go back to what I said about the PTH, it activates the vitamin D. So your inactive form drops because it's getting converted to the active form. So if I measure your active form in primary hyperparathyroidism, you'll see that it's actually high, but your inactive form is low. We only measure the inactive form. And so because of that, most patients with parathyroid disease will get diagnosed with vitamin D deficiency, and they will automatically be prescribed vitamin D. Why is that a problem? Well, if your calcium is already high and you start taking more vitamin D, you can raise your calcium into, a dangerous level by taking more vitamin D. So it is a little bit complicated, but basically, if you see a low vitamin D, don't immediately treat it. You want to know your calcium level as well. And if your calcium level is high, you don't want to take it. Now, the thing that is really confusing, and stop me if I talk too much because I love talking about vitamin D. The thing that is really confusing is that when you're deficient in vitamin D then causes your calcium level to be low. And that low calcium will then stimulate your parathyroids and raise your PTH. Now, this is a separate condition. This is called secondary hyperparathyroidism because your parathyroid glands are active, but only because they have to be, because you're not getting enough calcium. So they get activated, they make more PTH to try to get the calcium up if you have a severe vitamin D deficiency. In that case, you want to treat that with vitamin D because that will help get your calcium up, which will bring your PTH down. The place where doctors get confused is that they see the high PTH and the low vitamin D, and they ignore the calcium and they give you more vitamin D, but that's not going to solve the underlying problem. The underlying problem is a parathyroid tumor.
So just to clarify, what someone who does not have primary hyperparathyroidism, you do recommend the 25 hydroxy vitamin D test, like the
Yeah,
inactive form and not the active form of vitamin
right.
D as far as testing.
I do really for like I said, for most people, that form is the most accurate, and definitely the easiest to get. And like I said, if you just order it from the lab, if you just check off vitamin D, that's the one you're going to get. And I do recommend that. There are two populations really where it's not accurate. Primary hyperparathyroidism is one, and sarcoidosis is the other, because they also have an abnormal conversion to the active form. So there are those two scenarios where it's not going to be as accurate. But for almost everybody else, I would track the inactive form. Also because all of our recommendations and studies are done on the inactive form. So we don't have a lot of data on how to interpret or what to do with the active form. And where to adjust it to. Well, when we're talking about guidelines, we're talking about the inactive form.
And I agree. I test the inactive form 25 OH vitamin D. So thanks
Mhm.
for mentioning that. And so taking too much vitamin D can increase serum calcium. So what do you like to see vitamin D levels at? Like some will say at least 50 nanograms per milliliter. Some will say like between 60 and 80. Every now and then someone will say like greater than 80.
Yeah. Yeah, this is really controversial. And I do love this topic. So first, remember that I have a selected patient base. So the people who come to me are people generally who are worried about their parathyroids and typically have high calcium levels. And I will just say that when I see the high calcium level, I always check the PTH and the vitamin D levels. And if the vitamin D level is very high, there is a pretty good chance that it's causing the high calcium, as long as the PTH level is kind of on the low normal to low range. So, what I have them do first is I have them stop the vitamin D. Now you're kind of wondering, what level of vitamin D do I see it? I see it happen over 50 nanograms per mil. Now, lots of people can tolerate a vitamin D of 60 and not get high calcium. Those aren't the patients I tend to see. I tend to see ones where, if it's over 50, they end up with calcium levels kind of pushing into the tens. And it's not always recognized by their doctors that that's a high calcium, but I know that's a high calcium and that's going to cause the symptoms of high calcium. And so I typically recommend people keep it in the 30 to 50 range unless they're using vitamin D to treat something else. And I always encourage people to treat vitamins, any nutrient, any supplement you take, treat it as a medication. So have a reason why you're taking it. And there are people who are taking higher doses of certain vitamins in order to treat a condition or try to mitigate a condition or alleviate a condition, and that is okay as long as you know what you're taking and what the risks are. And with vitamin D, the thing you have to know is that there is a risk that your calcium level will go too high. So if you're on high doses of vitamin D, if your vitamin D level is 70, I don't know that there's not a lot of evidence that it really is beneficial to be 70 versus 50. But if you wanted to do that and keep it there, all I would say is watch your calcium level and make sure it's not going into the high range, because there are people who can tolerate vitamin D levels of 80 and their calcium level stays normal. Then there are people who get a vitamin D level of 60 and their calcium's 10.5 as a result of it. And they're going to get the symptoms of high calcium. And so you have to tailor it. There isn't one amount for everyone, but in general, I encourage people to keep it in the 30 to 50 range, because we have a lot of evidence that vitamin D deficiency, meaning true deficiency like under 15, does cause problems. And we likely have problems with under 30. That's not as clear. The evidence is not as good, but I think it's reasonable enough to say that there may be issues with under 30. So keeping it in the 30 to 50 range is kind of a nice medium for me, where I don't see it causing high calcium. And I think you're probably getting most of the benefits of vitamin D in that range. So that's where I stand on it. I usually have to, I know I'm going against a lot of other people, but that's because I see these effects. I see a lot of patients come to me with high calcium, and I do have to kind of caution them to keep it in that range. So if you don't want to, keep an eye on your calcium all the time, then 30 to 50 for vitamin D is a good range.
Okay. So 30 to 50 is where you like to see it. If
That's
someone
what I
insists
say.
on
Yeah.
taking, yeah, your opinion. And if someone,
That's my opinion. Yeah.
yeah, if someone insists on taking or having it where the level is like 50 or greater, you would just say monitor the serum calcium
Right.
just to make sure it's not
Right.
elevated. And if it's elevated, it might very well might be due to vitamin D. There is a
Right.
chance someone could have it could be still like
It
hyperparathyroidism,
could
even if
be.
someone's taking too much vitamin D too. They could
Right.
have that, or it could be a combination of both. But first thing is look at that serum calcium.
Right, right, exactly. And sometimes it is. Sometimes the vitamin D will kind of uncover parathyroid disease, sort of, maybe it was growing, the tumor was growing, and then as you take more vitamin D, it kind of easily slips into the tens. And that can be early parathyroid disease. But I do see it where, it starts going into the tens. And I also see it where it happens over time. And vitamin D, remember, is a fat soluble vitamin. So the longer you take these high doses, the more it's collecting up in your body. And it can take a while for it to drop, even if you stopped entirely taking any. And so I see these people who will be on these very high doses. And what I consider a high dose is 5,000 units a day, which is what a lot of people are on. But if you take that for a short period of time, it's unlikely that you're going to see bad effects from it. But I see these people who are on 5,000 units a day for 10 years, and then they didn't get high calcium level for the first few years. And it took a few years for the calcium level to start rising. And so, in their mind, they're thinking, well, I've been on this for so long, this can't be the problem. Well, it could be because you do see these effects add up over the years.
So based on what you just said, if someone, let's say they're taking vitamin D, let's say their vitamin D levels are like 60 or 70, and then their serum calcium is over 10. Would you recommend for them to just go ahead and test parathyroid hormone just to make sure it's not high or medium? Or would you just say, you probably would say stop the vitamin D anyway, but would you say another option, stop the vitamin D and wait a few months? Because it could take quite a while for that to drop significantly to impact the serum calcium, if that is indeed the cause of the elevated serum calcium.
Right. So first, I don't want to miss a parathyroid tumor, and so I will have them recheck labs with calcium, PTH, and vitamin D. And typically, when it's the vitamin D causing it, the PTH will be on that low end of normal. If it's not, so I do have patients where their calcium's 10.5, their vitamin D is 70, but their PTH is 100. That's primary hyperparathyroidism. Because the PTH level is definitely not responding appropriately to that calcium. So I know that's a parathyroid problem. Um, if the PTH level, on the other hand, is 25, on that lower end of normal, that's more consistent with vitamin D. And I do have them stop vitamin D. I mean, regardless, whether it's primary hyperparathyroidism or not, I tell them to stop vitamin D immediately because your calcium is high. That's the high calcium is what causes most of the symptoms and problems with parathyroid disease. And so you want to stop the vitamin D. But you want to stop that and then repeat labs. And yeah, 3 months is kind of the earliest I'll recheck. If it's that high because you've been on high doses for many years, it may take 6 months for it to drop down below 50. And that's really what I'm looking for, because once it gets down below 50, that's when I see the calcium drop back to normal. So that's what I have people do. And sometimes it takes 6 months, but it will happen.
All right. Thanks for explaining that, Dr. Deva. Um, Now, talking about primary hyperparathyroidism, if someone, has that benign adenoma, is there anything naturally, any natural options out there? Because again, a lot of people tuning into this, I'm all about when it comes to hyperthyroidism and Graves and Hashimoto's trying to, do things to improve the health of the immune system, try to address the cause of the problem, as are many other functional medicine practitioners, natural healthcare practitioners. But yeah, any other options besides surgery when it comes to the benign adenomas?
Sure. So, first, I will just say I am a huge proponent of lifestyle medicine and modifying your lifestyle, your diet, in order to treat and prevent disease. And for the thyroid, I think that makes a lot of sense. I also, as I mentioned earlier, I'm not a huge fan of surgery for Graves' disease. I think that really it's kind of that should be the you know um, you know last resort option after you've tried other things to control your thyroid. Um, Having said that, there are some things where surgery is just necessary. And for parathyroid tumors, there really isn't any lifestyle modification that you can make that will affect it, because it is a small tumor. It's benign, it's not a cancer, but it's a small tumor growing inside the parathyroid gland. And there's nothing really that will kind of get rid of it or cause it to go away without taking it out, at least anything we have right now. So the only treatment is removing this. And but I think that in that case, it really makes sense to have the operation, because it does have such a huge effect and you can cure it. For most people, once you take that parathyroid tumor out, or that parathyroid gland that's diseased, your other parathyroid glands react normally, and then you prevent all of the potential medications you might need to take later on down the road if you left it in place. Because a lot of people with parathyroid disease get high blood pressure, they get cardiac arrhythmias, they have fatigue, and they have constipation and reflux. So they end up on all of these other medications to try to treat the symptoms of this, when really a simple operation can cure it and prevent these complications.
So now, prior to going live, we were, as you mentioned, we were talking about Graves and how you recommend not having surgery unless, if like, as a last resort. Again, there's a time
Right.
and place, but one thing you mentioned is like with surgery of the thyroid, like complications are common, but with the parathyroid surgery, I guess it all comes down to also choosing the right surgeon too. Like same thing with the thyroid. If you
Right.
go, you wouldn't want to get thyroid surgery from someone who just did like 10 thyroid surgeries, or at least I wouldn't want to go to someone who was
Right.
not experienced. And obviously you
Right.
focus on that. So can you talk a little bit more about that, like potential complications, like the risk factors
Sure.
of this such a surgery?
Yeah, so especially with something like Graves' disease, that is my main reason for not wanting to push for surgery, because the complication rate is high. And actually, one of the big complications with surgery for Graves' disease is hypoparathyroidism, meaning all the parathyroid glands can be injured during the operation, and it's a serious, can be lifelong complication that can be very hard to manage if you don't have any parathyroids. And the reason it's more of an issue than with other thyroid operations, because not all thyroid operations are equal. Surgery for Graves' disease is one of the riskier ones because of all that inflammation around the thyroid. It makes it very difficult, and I've operated on Graves' thyroids. They are hard to deal with. They are very temperamental and they bleed easily and they're stiff, and it's hard to get around them. So for all those reasons, when you do a Graves' thyroid and you're taking that out, it is very easy to injure the parathyroid glands around it and not even realize it. And so, and also injure the nerve that controls your voice. So for all of those reasons, I say try to treat it medically, try to treat it with lifestyle medicine, medications, even radioactive iodine, before I would recommend surgery. But there are patients who need surgery for Graves, and they should get it. And if you do that, go to a surgeon who just does thyroid operations. There are people who really specialize in this and are mostly doing thyroid operations or solely doing thyroid operations, and that's who I would want doing my operation. But okay, so parathyroid surgery tends to be a very safe operation. It has some of the same risks as with thyroid surgery and with any operation, really. So anytime someone takes a knife to any part of your body, there is a risk of bleeding. That is true for parathyroid disease, like any other operation, but it's pretty low. There's always a risk to those nerves that control your voice, but again, pretty low risk. Um, and finally, there's a risk that you would injure or remove all the parathyroid glands, but typically you're trying not to do that. In general, it's a very safe operation. It lasts under an hour. It's usually about half an hour to see all the glands. And with this, as with other operations, you do want to get somebody who is experienced in this. A lot of general surgeons are credentialed to perform thyroid surgery and parathyroid surgery. It doesn't mean that you would want them doing your parathyroid or thyroid operation. Parathyroid surgery can be pretty hard if you're not experienced in it. So, those glands, as I mentioned, they're a grain of rice, and it could be a grain of rice that's stuck to the nerve that controls your voice. You really don't want somebody inexperienced digging around in there. You want somebody who is going to be able to evaluate it and remove the tumor safely and quickly, in order to just reduce those complications, get you out of the hospital. It's a same day procedure. So yeah, it's a very safe operation in general, as long as you have someone experienced doing your operation.
Yeah, if you had to take a guess, how many surgeries have you done?
Uh, so for me, I've done at least over 4,000, which makes me the most experienced person on the Western US, I think, because I've only done parathyroid operations for the last 10 years. That's all I focus on. For most surgeons, To me, I wouldn't want a surgeon who just did this operation once a week to do my operation. But a lot of the guidelines will say that you're an expert if you do 50 a year, which is about one a week. And that's not very many. I think to get good at this, you have to do a lot of operations, and that just, it means kind of specializing in the area, which a lot of surgeons aren't doing. Um, I will say the thing I do differently is that I look at all four parathyroid glands in the operating room, because that's really the only, it's the most accurate way and most reliable way to actually assess the parathyroid glands. Scans and imaging studies are so often wrong with the parathyroids because they're so tiny to begin with. You can't see normal glands, and you can't even see small tumors. So I have a lot of patients who have completely negative scans. And this is weird to think about, because when I say you've got a small tumor, most people in their mind are thinking, okay, you know that because either you see a lump or you feel a lump or you see it on the scan, right? If I say you've got a tumor, you're thinking about a scan or like a lump you have on your arm, something. With parathyroid disease, it's not like that. I can't feel it on your neck. We can't see it. A lot of times on imaging studies, we don't see it at all. Even with the most, advanced imaging studies we have, they may not show up. And so you have to base it on the labs. And I know from your labs, you've got a parathyroid tumor. It's a little weird to say, yeah, I don't see anything on the scans, but I know you've got a parathyroid tumor. If I go in and look at your parathyroid glands, I'm going to be able to figure it out. But that means going in there and being able to find all four safely and quickly. And for most surgeons, they often won't do that. They will rely solely on imaging. So they will only operate if they have a positive scan. And then they'll only go after that gland. And that does lead to a lot of patients kind of needing further surgery in the future. I avoid that by just looking at all four parathyroid glands during that one operation. So it's a one and done procedure.
All right. No, thanks for bringing that up. That's really important to know. Because yeah, I guess if a surgeon relies on finding it on a scan, and if it's there, but it just doesn't show up on the scan, then that person's going to be just continuing to have the symptoms associated with,
Right.
with the elevated calcium levels, the hypercalcemia, and yeah. So, and like you said, eventually they'll probably get the surgery when they get maybe a second or third
When they
opinion,
find
and
another
then
surgeon.
yeah,
Yeah.
exactly.
Yeah. Yeah.
Yeah. All right. Well, you shared a lot of information, Dr. Diva. Is there anything else that I should have asked you that I didn't ask you, or any last words that you have for those that, might be suspecting that they might have an issue with the parathyroid glands?
I think that's covering a lot of it. I mean, it's a lot of information in a short period of time. So, and if your fans don't know about much about the parathyroids, it's kind of overwhelming. Um, but I would say my advice to all people is to get your own medical records, get your lab results, look at them yourself, and if you're having symptoms, to uh, get a second opinion. Read through your results yourself and do your research. Some doctors really don't like patients looking up their illnesses on Google. I'm fine with it. I think that's great. I mean, you can learn a lot online and through reading. And a lot of my patients figure this out themselves because they're really tired and they have headaches every day and they can't figure out why. And they finally get their lab reports themselves and they see that the calcium is high and has been high, but nobody's mentioned it. And then they finally find me online and get treated for it and they feel better. But it's one of those things where your doctors may miss it. This is one where they often don't take it as seriously, or they'll kind of give a wait and see attitude to just watch it over time. And so you really need to kind of take control of your health and remember that nobody's going to care about your health as much as you do. And so you need to advocate for yourself, and that's definitely true with Graves' disease as well. There's some things that we learn for Graves' disease that I have learned are not true and disagree with, and have changed my my practice based on that. So yeah, just take control of your own health.
All right. Well, thank you so much. And where can people find out more about you?
Sure. So my center is Southwest Parathyroid Center. If you go to southwestparathyroid.com, you'll find me. And also, I have my own Facebook page and answer a bunch of questions there. And you can go to parathyroidq&a.com, where I answer a lot of questions too, like any question about parathyroid disease.
All right, wonderful. I'll of course make sure to include the links in the show notes. And thank you so much, Dr. Deva. Really appreciate you taking the time to talk about, the parathyroid glands, the hyperparathyroidism, as well as also diving into vitamin D.
Sure. Yes. Thank you for having me. And yeah, if people have questions, they can always reach out to me through my website too.
All right. Well, thank you. And speaking of questions, if there are any questions, definitely let us know. Just enter in the comments, and Dr. Diva will. She said she'll stick around for. You're okay for a few minutes, just
Oh yeah.
for any questions. Okay.
Yeah.
Um, Actually, we have one here. It looks like in the Facebook group. Looks like it's related to hyperthyroidism.
Yeah.
Can I? Okay. Can I ask your thoughts on the impact of using? Okay, this might have to wait because it looks like there's a website. But on using a vagus nerve stimulation device on the thyroid, if you have hyperthyroidism, this device improves sleep, reduces stress and anxiety by restoring the balance of the autonomic nervous system. But it does so by using mild electromagnetic signals that release the thyroid. So yeah, I'd have to look into that. I'm not sure if Dr. Dev is familiar. I can't say I'm familiar with this device.
Yeah. I am not. Are you? Yeah, I'm not familiar at all. If it's an implantable device, I mean, um,
Yeah, my
yeah.
guess is it's probably not implants. I mean, I don't know for sure.
Okay.
I'm not familiar, but I
We do have
think it's
nerve stimulation, implantable, but
yeah,
yeah, I don't know. I have no
yeah.
opinion on this,
Okay, yeah,
but
Ron,
shouldn't affect
yeah.
your parathyroids, definitely.
All right. Any other questions? Any questions related to especially like vitamin D or parathyroid glands? One question while we're waiting to see if any questions come in. Do you mind me asking how much vitamin D you take on a daily basis? Or
Sure. For most people, I recommend 1,000 to 2,000 units a day if they do need to take it at all. For me, I do the economical thing. I buy 5,000 unit pills and I take one a week. So,
okay.
so that averages it out to a little bit under 1,000 a day, and that's what I take, and that's been pretty good. And I only do that, interestingly, because my calcium level was kind of trending on the low end a few years ago. And so when I started taking vitamin D, that corrected and my calcium went to the mid nines. So it's only because I care about my calcium that I take that vitamin D. But it's much easier for me to remember once a week and much cheaper because you can buy a huge bottle and take it forever.
Yeah. Do you also take a lot of now practitioners talk about, including myself, like vitamin K2 to like help guide the calcium into the bone or?
K2 is interesting. I get a lot of questions about vitamin K as well. So the thing is, most people probably get enough. As I'm sure you know, vitamin K is produced by bacteria in the gut. And so if you've got otherwise a good functioning gut and diet, then you're likely already making enough vitamin K that taking extra probably doesn't have a huge effect. Um, there were studies in Japan with like high doses of vitamin K, and that seemed to maybe help the bones. I think for most people, it's really not necessary. So, you know, I think if you want to take extra vitamin K or vitamin K2, you'll be fine taking it, but likely you probably don't need it. So I do try to get people to kind of focus on the things that do probably matter a little bit more. Like if your calcium level is really low, um, taking the vitamin D is important. Taking magnesium is important for your bones, and calcium, of course, if your calcium is low. So I try to minimize the things I tell people to take, knowing that, psychologically, it's hard when you're taking a ton of stuff unless you're really, really dedicated to it. So I try to get people to focus on sort of the basics that I really think are going to make a difference.
Yeah, and one other thing, I think we do have a question came in, but I admit I've been guilty of taking like high dose, like 5,000, not per week, but per day, just like the
Yeah.
five. And again, I usually like to see my levels like in the upper 50s, low 60s. I can't say I strive for like 80s or 90s, and um, but yeah, again, just so interesting, like as far and again, I do keep an eye on my serum calcium too. So
Yeah.
like I do a comprehensive metabolic panel, and but like you said, maybe like so far it's been under 10, maybe
Hmm.
like 9.7, 9.8, and I'm in my
Yeah.
50s right now, um but again, like you said, maybe it could be a matter of time too. Like maybe it's normal now, but I probably, if I were to stick with that same dose, which I know you wouldn't recommend, but if I were to stick with
Yeah.
it, you would say probably just keep an eye on the calcium and just make
Yeah.
sure it doesn't like over time go up.
Right. And just keep an eye. I mean, that's the thing really, is that I know there are people, because people do contact me and say, "Well, I take this and I'm fine." And I'm like, "Okay, well, I mean, everybody's different. Everybody needs a different, that's why we have different medications that come in multiple doses. I mean, not everybody needs the same amount. And there are people who do not seem to process vitamin D as well, and they have to take 5,000 units a day, every day, lifelong, just in order to maintain a vitamin D that's in the 30s. If that's the case, then that's fine for you. It's just, treating it with respect, treating it like you would a medication, right? You wouldn't just take more and more of a medication, of your blood pressure medication, thinking, well, if a little bit's good, then a ton will be better. And you would kind of consider it based on your blood pressure and the effects that it has on it. And I would just say the same thing, pay attention to the effects that it has on your calcium, because that is kind of the end result of vitamin D.
Yeah. All right.
Um,
Let's see. We got so it's not, yeah, it's the device, the vagus nerve hangs around your neck. Um, and then this question, I have Graves. I'm taking, okay, she's also taking 5,000 IUs of vitamin D per day and 200 micrograms of K2. I worry about high calcium, just really uncertain what I should do for the best, because this person is susceptible to low vitamin D. So kind of, I guess what you were saying, I guess if this person feels the need to take, like if they're, if not feels the need, but if like their levels will drop below 30 unless if they take 5,000 IUs, you would say it's okay for them to continue with that, or?
Right. Yeah. I mean, if your calcium level's staying in the normal range, and especially the vitamin D, I mean, typically, like I said, if the vitamin D level is going to cause high calcium, it's typically going to happen when the vitamin D is over 50. If you're taking 5,000 units and your vitamin D is continually 40, that and your calcium levels normal range, then that's okay for you. But for whatever reason, you need that dose. But it is just, keep an eye on the calcium, and remember that really over age 40, your calcium level should be in the nines. So if it's going into the tens, 10.1, 10.2, that's a problem. You probably want to cut back on the vitamin D. But everybody's different. And so I would watch your levels rather than the absolute dose. For me, most people seem to do well on 1,000 or 2,000 units a day and don't really need higher doses, but there are exceptions.
All right. And I think this is a following on the previous comment. I'm in the UK and vitamin D range is different. Oh yeah. So
Yeah.
nanomoles per liter. So they use the, yeah,
Hmm.
nanomoles per liter range.
There are great converters online. So I know, when we talk, we're talking about nanograms per mil, because that is the US range. But in other countries, that is not the most common. You get nanomoles per liter. But online, there are ones where you can just type it in, and see the converter. So if it's confusing, I understand. I understand the confusion. Um, Let me see. If you go to, uh, let's see. So a 50 in nanograms per mil, which is the number that I'm talking about, the US number, would be about 125 in nanomoles per liter. So you can have a much higher level. So your 50 and in your units would actually be like a really a low vitamin D level. So yeah, you do have to do the conversion. But if you're in the UK, 50 is 125.
All right. Yeah. Thanks for mentioning that. And uh, yeah, would you agree that also, in addition to supplementation, it's good to try to get as much vitamin D like through like sun exposure too?
Yeah, I mean, I think that it is reasonable to try to get most things through diet and if you can, and vitamin D is one where yeah, you get it through sun exposure. Um Obviously, you don't need a lot for that. And there is this sense that if you put sunscreen on, that you are eliminating the vitamin D, and that's not really true. Actually, even if you put sunscreen on, if you're out in the sun for a while, you are converting some vitamin D, even if you have that sunscreen on. So it's not like the sunscreen negates it. You don't need to go out for hours without sunscreen, and I wouldn't encourage anybody to do that because it's bad in other ways. We don't want people getting skin cancer for this, but there is evidence that even if you put sunscreen on, you still will convert vitamin D. Some people still can't get enough, even with that, and so it's you know taking a moderate dose of vitamin D is safe for most people.
All right. I think we're out of questions. If there are no last questions, we will call it a day, and I'll let Dr. Diva enjoy the rest of her Friday and weekend. Oh, actually, hold on here. Are
Hmm.
finger prick tests for vitamin D reliable, or best to have a blood? Is it best to have a blood draw?
Huh. Um, Interesting. I haven't had anybody ask about finger prick tests for vitamin D. There are few tests where that can really be done. I mean, where it can be done theoretically for a lot of different things, but often for something like vitamin D, I don't know that that's offered in a lot of places. A finger prick, I would say, to get it drawn, mostly because if you're getting all the other stuff drawn, you'll want to get that done with a blood draw. Something like when you're testing vitamin D, you also want to see a basic metabolic panel with the calcium. So I don't know. I haven't heard of anybody getting vitamin D with a finger prick.
Yeah, I don't know either. I'm not sure if that's it's just as reliable, and yeah, like you don't know where I would get one. I mean, it wouldn't be a shocker if some labs offer it, but yeah, I agree. I get mine. I just go for a regular blood draw when I get vitamin D tested.
Yeah.
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 All right. Well, thank you so much, Dr. Diva. Thanks for again all the information you shared. Thanks for sticking around for a few minutes to answer questions. And again, yeah, if anybody again thinks that they may need, I guess one other question. You see people from all over the country too. So if someone's
Mhm.
not you're in Scottsdale,
In
Phoenix,
the world.
Arizona.
Yeah,
So
I'm in
yeah,
Phoenix. Yeah. Yeah, I get
yeah.
patients coming from all over the world and or just consulting from anywhere about parathyroid issues. So, yeah.
Yeah, would they need to fly in for a consultation to determine if they need a surgery first though, or what could they do?
No,
Is that
most of the
something they could?
time we do a video call.
Okay,
So there are some people who want to meet in person, but I much more often will do a video call, and then
okay,
if you fly in for surgery, I meet you the morning of surgery and talk then. But typically it's actually about more than half of my patients fly in for surgery, so it's very common for patients to just do a phone call with me or a video call like this and then meet me the morning of surgery.
okay.
Yeah.
Wonderful. Well, again, if anybody is in need of Dr. Diva, definitely reach out to her, check out her website. And again, Dr. Diva, thank you again for your time today and for, again, answering some questions.
Yes, you're welcome. And thank you for having me on. This has been fun. And to anybody out there, you can always reach out through my website.
All right. Well, thanks everyone. Everyone have a great rest of your Friday and a wonderful weekend ahead. Take care,
Yep. Have a
everyone.
good weekend. Bye.